Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome back. Welcome back to the AMC ICPT Guideline Mastery Series. Okay, hello everyone. How are you all doing? Let me know in the chat who all are we having here today. So we have hi Miss Mills. Miss Mills is there in the chat. Hi Catherine Coder. Hi Lily May. Hi Patty. Okay, I can see a lot of people are joining here. Hi, Letty. Hi, everyone. So, once again, welcome back to everyone. So, today is not just another class, it's another step towards becoming a confident, guideline driven coders. Yes, so here at AMCI, as I always say, we believe coding is not about just memorizing the codes, it's about understanding why behind every guideline. Okay, so in this session, we are going to simplify the complex concepts, connect the dots, and work through the scenarios that reflect the real coding decisions. Okay, and you can get your code CPT codebook ready, stay focused, and think like a coders, not just like a learners. Okay, so because at the end of this session, you will no, just won't know the guidelines, but you will know how to apply them as well. So let's break it down together. Let's think it through and let's master the CPT guidelines together. Okay, so please let me know, coders, how do my mic sound? Am I audible? Hi, Starry Sunny, welcome back. Okay, so I can see a lot of familiar faces here. So let's begin with the copyright. CPT Copyright 2026 American Medical Association. CPC is a registered trademark of the AAPC. AAPC content found within this presentation is a copyright of AAPC. The keyword concept FTR, CHON, AMCI, FAB7, AMCI, ICD-10, FlipTab, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. Okay, so thank you for letting me know that my mic sounds good. Hi, Veena T. Okay, so in today's session, we are going to review the respiratory system procedure coding. Okay, and we will understand mainly the different surgical approaches which is used in the lung and pleura procedures. We will clearly differentiate between a thoracoscopy versus thoracotomy versus the percutaneous procedures. We will learn how the approach impacts the code selection and also break down the key CPT guidelines for the respiratory procedures. All right. Now, before we begin, let's first understand where to find today's codes in your CPT manual. So today we are going to review the respiratory system section, which falls under the surgery chapter of the CPT, and specifically we are going to look into the lung and pleura procedures. Okay, so before we dive into the procedure, let's quickly understand the anatomy of the human respiratory system. So we divide actually the human respiratory system is actually divided into two parts. One is your upper respiratory tract and the other one is your lower respiratory tract. So the upper respiratory tract consists of your nasal cavity, nostrils, pharynx, epiglottis, and larynx. So these structure mainly help with the air entry, filtration, as well as the passage. Now, coming to the lower respiratory tract. Lower respiratory tract begins right below the larynx, and they include your trachea, bronchi, lungs, and the pleural cavity. So this is where the gas exchange and most of the procedures happen. So the procedures which we are going to discuss today especially the lung biopsy and the resections, are performed in the lower respiratory tract. All right, so I can see people are saying that the screen is bit small. Okay, now the screen is bit small because you are logged into the desktop, sorry, the mobile version of the live stream. So if you can just, we have another video which is running parallelly that is specifically dedicated for the web user. So if you can turn into the web screen or web stream, that would be good, so you can see everything a bit large. Okay, please let me know if it helps, and if someone can place a link for the mobile users, that will be also great. Okay, all right, so let's move on, and this is about the anatomy of the respiratory tract. Now, again, our human lungs are divided into lobes. Did you know that? Yes, the right lung has three lobes. Okay, first one is your superior lobe, then comes the middle lobe, and the lower one would be the inferior lobe. At the same time, your left lung only have two lobes. Yes, that's interesting, right? The left lung has only two lobes, namely the superior lobe, which is the upper lobe, and the inferior lobe, the lower lobe. Okay, so again, this is how the lung is divided, and the procedures that is performed on the lung and pleura are primarily classified based on their approaches used to access the thoracic cavity. So let's begin with the first one, that is a percutaneous approach. Now, in a percutaneous approach, the needle will be inserted through the skin. So it will be a small needle, and there won't be any large incision, and these procedures are usually performed using the image guidance such as CT, ultrasound, etc. And such procedures are, as you can see, is minimally invasive. Now, in example, you can have the needle biopsy, the thoracosynthesis procedures, etc. Next approach, that is thoracoscopic approach, or otherwise you must have heard about the video assisted thoracic surgery, right? So they fall under thoracoscopic approach. And here we will use a small incision. There will be cameras, otherwise scopes used. Also, these use special surgical instruments. Now you can see in the screen how a video assisted thoracoscopic surgery will be performed, and these procedures are also less invasive compared to the open surgery, and the recovery is also much quicker compared to the open surgery. Okay, now in example for thoracoscopic surgery, you can consider a Watts biopsy, Watts lobectomy. So these are the examples of thoracoscopic surgeries. Now coming to the third one, third approach, that is thoracotomy. Yes, this is for open approach. All right, so here a large incision will be made in the chest wall, and we usually use the direct visualization. It is used to obtain the direct visualization of the lungs. Okay, and this is the most invasive approach among all the three. And in example here, you can have the lobectomy, the pneumonectomy, etc. All right, so these are the three different approaches that is used to access to the thoracic cavity. Great. Fine. Thank you, Miss Mills, for sharing the link. And hi, Miss Brenda. Okay, so Miss Mills have shared the desktop view link. So those who are in the mobile version, if you want desktop view, you can join there. All right. Okay, so before we jump deep into the lung coding, let's take a quick review of some of the most common lung resection procedures. So starting with the wedge resection. Okay, so think of this like a cutting out small slice of cake. Yes, a wedge resection removes a small triangle shaped piece of the lung tissue, including the abnormal area and a tiny margin of healthy tissue as well. So goal here is to remove the problem while preserving as much lung as possible. And next we have segmentectomy. Now here, instead of a slice, we remove a defined portion of the lung called as segment. Yes, now for this you can think of like an orange. Okay, each segment is like one section of that orange, and this is more extensive than the wedge, but still lung sparing. And next we have lobectomy procedure. Here we go. Yes, this is much bigger, and a lobectomy removes the entire lobe of the lungs. So you remember that I've said lung is divided into multiple lobes, right? So here one of such lobe will be completely removed. And this is one of the most common procedures for lung cancer. And finally, we have the most extensive one, the pneumonectomy. Now, this is a complete removal of one entire lung. Okay, and this is reserved for the more advanced or otherwise widespread disease or widespread cancers. Okay, so these are some of the most common used resection procedures in the lungs. I hope the explanation helped. And now we are looking at the CPT codes for the thoracoscopic procedure. So the thoracoscopic procedure in your CPT manual can be classified, or they are classified based on like there are diagnostic procedure codes as well as there are surgical codes. So as you can see, the code series ranges from 32601 to 32674. These are for the thoracoscopic procedures. Then we also talked about the open procedures, right? So open procedures are done using thoracotomy, and CPT also classified the thoracotomy procedures into two, like one for the like diagnostic classification as well as surgical classification. Okay, and the third one, percutaneous, we will cover towards the end of this session. So let's move on. All right. Okay, now let's have a look into the CPT guidelines on the diagnostic versus therapeutic wedge resection. And keep in mind, coders, for this section or under this guideline, the intent that matters a lot. Okay, all right. Now let's start with the biopsy. So you all know that a biopsy is all about gathering information, right? So during a biopsy procedure, surgeon will take a small sample of the tissue to determine exactly what is going on. Okay. And in the other hand, we have resection. Now, resection is all about removal and treatment. Yes, the surgeon here is actively removing the abnormal tissue. And these procedures can be performed by different approaches such as VATS as well as open procedures such as thoracotomy. Okay, so these procedures can be done either by thoracoscopy or by thoracotomy. Now, here is a key concept you must remember. Okay, the wedge resection can be done, can be both diagnostic as well as therapeutic. So, intent is what matters the most. So, for such scenarios, ask yourself, is the surgeon trying to diagnose, or are they trying to treat and remove completely? Because in coding these procedure, intent changes everything. Now, think of a diagnostic procedure as an investigation. Surgeon goal is to identify the problem and not fix it. Okay, not fix it yet. So only sample is needed, and margins are not the focus in such scenarios. And now therapeutic procedure, we are in the treatment mode, and the condition is already known, and the goal is to completely remove. And in such cases where the therapeutic procedures, the margins matters a lot. Okay, so margins means there will be some extra tissue which will be taken that will be normal healthy. Okay, so in biopsy procedure, margin is not that much important, or in a diagnostic procedure. While for a therapeutic wedge resection procedures, margins matters a lot, and it involves complete resection. Okay, so that is a key difference between the diagnostic and therapeutic wedge resection. Okay, one more thing, coders. We cannot actually determine how to code a wedge resection before the procedure is over, because whether it ends up in a diagnostic or therapeutic is actually decided real time in an operative room. All right, so let's picture this. When a surgeon when a surgeon removes a diagnostic or removes a wedge of a tissue that is suspicious for nodule, you can see the step one, surgeon performs a wedge resection. They immediately send out to the pathology for the analysis of frozen section. And the surgeon actually waits for the result. So step two, the surgeon sends out for the intraoperative pathology and he's waiting for the result. Now, what the pathologist reports next will determine every decision moving forward. And that pathology report result boils down to one important question. Do we need to remove more tissue from the exact same spot, from the same lobe or the same lung, or not? So based on this result, we can have two scenarios or two outcomes. Okay. Now in scenario one, if the pathology reports malignancy and the margins are not clear, in such cases, surgeon has to go back and remove more tissue, and it requires a more extensive resection like lobectomy. So in such cases, initial okay, just give me a second. Okay, so we are back. Just give me a second, coders. I will fix the screen. All right, so let me go back to where we stopped. Okay, so I was telling that we cannot determine how to code the wedge resection before the procedure is over, right? Okay, is my screen visible now? Please let me know in the chat. So, first step, the surgeon will perform a wedge resection, then specimen is sent out for an intrapathology report, and pathologist will deliver the result. So as I said, there will be two kind of scenarios. One in which the pathology reports malignancy and margins are not clear. So in such cases, surgeon has to go back and remove more tissue and requires more extensive resection like a lobectomy. So in such scenarios, initial wedge resection will get reclassified as a diagnostic wedge resection. Okay, because its purpose was to guide the decision for a more extensive surgery and not just to treat the condition. Okay, so based on the first wedge resection, it went for an intrapathology consultation. Result came out that saying that it's positive for malignancy, and there are still still malignant tissues left. So surgeon had to go back and do an extensive procedure, such as a lobectomy. So the initial wedge resection will be reclassified as a diagnostic wedge resection. So is that clear, Coders? Okay, so if a diagnostic wedge resection is immediately followed by a bigger procedure like a lobectomy, where they take out the whole lung lobe and it's all in the same lobe, you will report the major procedure and an add-on code to indicate that the preliminary diagnostic wedge was part of that process. And when diagnostic wedge resection is followed by an extensive procedure in the same anatomical location, you can report the add-on code 32507 or 32668 with more extensive procedure. So in this case, if a lobectomy is performed and there was a diagnostic wedge resection that led to the lobectomy, which is a much more extensive procedure, and all of this happened in the same lobe, in the same lungs, in such cases, we will first report the lobectomy code with an add-on code that can be 32507 or 32668, depending upon whether it was a thoracotomic procedure or a thoracoscopic procedure. All right. Okay. Now let's move on to the second scenario. Second scenario is when pathologist reports back that the margin is clear and no extensive resection is required. Now, in this scenario, the wedge resection will be classified as therapeutic procedure or therapeutic wedge resection because it was final definitive treatment and it solved the problem. So you have to report the therapeutic wedge resection code based on the procedure was, or whether the procedure was open or thoracoscopic. So the CPT code used would be 32505 or 32666. Okay, so these were two scenarios. Now, the CPT guideline states that therapeutic wedge resection codes 32505, 32506, 32666, or 32667 should not be reported in addition to the more extensive lung procedure such as a lobectomy unless therapeutic wedge resection was performed on a different lobe or on a contralateral lung. Whether or not intraoperative pathology consultation is used to determine the extent of lung resection. Now, in the scenario where the resections are in different lobes, example, if the surgeon does a therapeutic wedge resection of a benign nodule on the right upper lobe, and in the same surgery, he does a full lobectomy of the right lower lobe, in such cases, you can code for both procedure and add a 59 modifier on the wedge to show that it was a totally distinct procedure. Okay. And finally, we are moving on to the next topic. So until now, we were focusing on the wedge resection procedures, but now we are shifting gears and moving into the biopsy procedure. So this is where many students actually get confused. So let's make it very clear. Don't mix up the wedge resection guidelines with the biopsy guidelines. Now, here is the key concept you need to understand. If a diagnostic lung biopsy is performed, no matter the approach, whether it be an open approach, whether it be a thoracic approach, and no matter the technique, that it be an incisional cautery or staple wedge, and specimen is sent for intraoperative pathology, and during the same surgery the surgeon uses those results to decide to perform a more extensive procedure like a segmentectomy or lobectomy, you will only report the extensive procedure performed and you do not report the biopsy separately. Now, because the biopsy in these cases is considered as a part of a decision making process for the final surgery. All right. So, if a biopsy procedure led to a more extensive procedure, you will only report the extensive procedure performed and not the biopsy procedure. Okay, coders. Now it's time for us to check what we have learned. All right, so we will move on to some hand poll scenarios based on these guidelines, and you can place your answers in the chat. Okay, first one code is, what is the correct coding? A wedge resection is performed to obtain a tissue sample only without attention to margin. What will you code? Will you code a therapeutic wedge resection, a diagnostic wedge resection, a segmentectomy, or option D, lobectomy? Okay, when a wedge resection is performed to obtain tissue sample only without attention to margins. Okay, so that's a keyword, without attention to the margins. Okay, I can see some answers in the chat. Great. Great. You all are super forensic. I thought this will be a little bit confusing or a little bit tough question. Okay, coders, give your best answers. Don't worry even if you're getting it wrong. Give your best answers. Okay, yes. The correct answer is option B, diagnostic wedge resection. Excellent. Because I said it in the beginning, right? A diagnostic lung biopsy or diagnostic biopsy of a lung nodule using a wedge technique requires that only tissue sample is obtained without particular attention to the resection margin. And it is the therapeutic wedge resection where the margins matter. Great coding, great coding. Good to see. Let's move on to the next question. A therapeutic wedge resection performed in the right upper lobe, a lobectomy performed on the right lower lobe. What is the correct coding? Option A, you would report only lobectomy. Option B, you would report a wedge only. Option C, you would report both without modifier. Option D, report both and append a 59 modifier. What say you, coders? What do you think? Okay, I will repeat the question in meantime. You can place your answers in the chat. A therapeutic wedge resection performed in right upper lobe and lobectomy performed on right lower lobe. All right. So, okay, so both are performed on. All right, there you go. There you go. Awesome. Fantastic. Outstanding. Outstanding answers. Yes, you all are absolutely right. Yes, we would code both CPT codes and append a 59 modifier, right? Because both happen on a different lobes. So the guidelines stated that therapeutic wedge resection codes should not be reported in addition to an extensive procedure unless, that's a keyword, unless therapeutic wedge resection was performed on a different lobe or on a contralateral lungs, whether or not an intraoperative pathology consultation is used to determine the extent of the resection. So if the therapeutic wedge resection and extensive procedure is performed on two different lobes or on a contralateral lungs, you can report them separately by SI appending 59 modifier. Okay, let's move on to the next one. It's getting interesting. Okay, what is the correct coding? A therapeutic wedge resection is performed. A frozen section shows malignancy, and the surgeon proceed to perform a lobectomy of the same location. Okay, same location and same lung. What is the correct coding? Is it option A, therapeutic wedge plus lobectomy? Option B, lobectomy only? Option C, lobectomy and an add-on code for diagnostic wedge? Or option D, wedge only? Now, this is a good question. Let me know, coders, what you think. Okay. Okay, I'll repeat the question again. A therapeutic wedge resection performed and frozen section showed a malignancy. So surgeon has to go back and perform a lobectomy. And all that happened on the same location. All right. Okay. Mm-hmm. All right. Okay, okay. So this is going to be, I would say, this is going to be an aha moment. Okay, so the correct answer is going to be option C, a lobectomy and an add-on code for the diagnostic wedge resection. Because Coda, you remember, as I said, yes, it was a wedge, therapeutic wedge resection that was initially performed, right? And that wedge resection, the frozen sample or the frozen section was sent to the intrapathology, sent for an intrapathology laboratory, and that laboratory result came out to be malignant, and because of that, surgeon had to proceed to do an extensive lobectomy of the same location. So, as per the guideline, yes, there you go. Someone has said, okay, great, great. So, as per the guideline, that therapeutic wedge resection would be reclassified as a diagnostic wedge resection because that was not the final procedure, isn't it? That resection wasn't the final procedure. And because of that result, first surgeon had to further go and do a much extensive procedure, that is a lobectomy. Okay, so in such cases you have to assign the extensive procedure first, followed by the add-on code for the diagnostic wedge resection. Okay, okay, so that's fine. If you learn something, that is priceless. Don't worry, we will do some scenarios based on this guideline so that you can get much more stronger idea of this guideline. Okay, so let's go ahead and let's choose some scenarios. Okay, Coda. So I'm not going to give you 2.5 minutes for this one. You can answer quickly because we are already crossed the half hour time. Okay, so of the following answers, which best CPT code describe the scenario? Option are option A 32097, option B 32608, option C 32607, option D 32666. A 72-year-old with a history of smoking presents with a newly identified lung nodule. During the thoracoscopy, multiple lung nodules are unexpectedly discovered, raising concern for a metastatic disease. The surgeon proceeds with an incisional diagnostic biopsy, and pathology confirms metastatic cancer. Of the following answers, which best describes the scenario? What say you, coders? All right, coders, that is almost time. Yes, go ahead. Place your best answers in the chat. Okay, don't worry. Don't worry even if you get it wrong. So this is a straightforward scenario. So no guidelines is applied to this one. Okay. Okay. All right. All right. I can see answers are coming. Okay. Great. So let me walk you through this one. Okay. Uh, there you go. So let's have a look into the CPT code. So we have CPT code 32666. That is coding for a thoracoscopic surgical procedure with therapeutic wedge resection. And in our inventory, so first I have to read the diagnosis inventory. In diagnosis inventory, we're having a lung nodule. Procedure inventory, we have a thoracoscopic biopsy of the lung nodule performed. So looking into the inventory, comparing with the code option 32666. 32666 is coding for a thoracoscopic wedge resection. Did we have a wedge resection performed here? No, right? We didn't have a wedge resection, and it was an incisional diagnostic biopsy that was performed. So it is not going to be option D. Option D, you have to go wrong. Okay, it's wrong. All right, let's look into the next one. Next CPT code is for 32097. 32097 is for thoracotomy procedure. Now, did we have a thoracotomy procedure? Because you all know that thoracotomy is an open procedure, right? Did we have an open procedure done here? I don't think so, because documentation clearly stated that we had a thoracoscopic procedure, not a thoracotomy, and that eliminates option A. Now between option B and D. Okay, I know that my on clicks are wrong, so please forgive me for that. So option C, 32607, is coding for thoracoscopic with diagnostic biopsy of the lung infiltrates, while option B, 32608, is coding for thoracoscopic with diagnostic biopsy of lung nodule or mass unilateral. So did we have a biopsy of a lung infiltrate or a lung nodule done? I think it was a biopsy of lung nodule. Am I right? Not a lung infiltrate. Yes, the documentation stated that we had a lung nodule biopsy performed, and that will help us eliminate option C, and the correct answer, as most of you went with option B. Option B is the correct answer. So my on clicks are wrong for this. It will be showing option C as the correct answer. So it's wrong. Option B is the correct answer. Okay. 32608 is the correct answer. Yes. Yes. Great. Yes. Absolutely correct, Mia. Okay. So option B is the correct answer for this scenario. Let's quickly move on to the next one. Exercise number 2. Of the following answers, which best CPT code describe the scenario? Option A, 32666. Option B, 32663. 32668. Option C, 32663. Option D, 32480. 32507. A 62-year-old male with a history of colon cancer presents with an enlarging nodule in the right upper lobe of the lung, suspicious for metastatic disease. A therapeutic right thoracoscopic approach is performed, and a wedge resection of the right upper lobe is completed. Intraoperative pathology confirms metastatic colon cancer. During the same procedure, the entire right lobe is subsequently removed thoracoscopically. Of the following answers, which best describe the scenario? Alright, coders, your time has begun. Remember the guidelines which we have reviewed just few while ago. Okay, yes, you're correct, Miss Mia. Chun makes a big difference, and as you said, that helps to pick up the correct answers quickly, especially during the exam. So go ahead, coders, churn your manual. Okay, coders, that is time. And I can see one answer in the chat. How about the rest of you? Let me know in the chat, coders. Place your best answers, and then we will go ahead and we will solve it together. Okay, okay. I can see one more answer. Good. Okay, go ahead, go ahead, go ahead. Place your answers. Give your best shot. Okay, so let me go ahead and let's move on to the next slide. So here we have in diagnosis inventory a patient with a metastatic. It was proven that patient is having metastatic colon cancer, right? And there was a enlarging nodule in the right upper lobe of the lung. And in the procedure inventory, we have a metastatic, sorry, in the procedure inventory, we had first a thoracoscopic wedge resection of the, and then a right upper lobectomy was performed. All right. So in this scenario, as the scenario which we reviewed previously, first a therapeutic right, a therapeutic wedge resection of the right lobe was done, and an intraoperative pathology was sent out, and it confirmed to be a metastatic colon cancer. And because of that, doctor had to go back and remove the entire right upper lobe. Right, and all this happened in the same session. So as per the guideline, we all know that the initial therapeutic wedge resection would be reclassified as a diagnostic wedge resection, right? Yes, in case of a wedge resection in which the intraoperative pathology consultation determines that a more extensive resection is required in the same anatomic location, it becomes classified as a diagnostic wedge resection. And then you have to use the more extensive procedure code along with the add-on code. It can be 32507 or 32668 depending upon whether it was an open procedure or it was a closed, sorry, it was a thoracoscopic procedure, right? So that is the guideline. And with this guideline, I can see that option A is wrong. Option A is coding for only for a thoracoscopic wedge resection procedure, right? So we had a lobectomy performed, and you have to code for the add-on code as well. So 32666 is wrong. Option C is also incorrect. Even though the CPT code looks great, it's coding for 32663, which is for thoracoscopic surgical with lobectomy. Yes, we have to code for thoracoscopic lobectomy, but with that, you have to use the add-on code as well, right? So option C is wrong. That is not using for an add-on code. Option D is coding for 32480. Now this is coding for a removal of lung other than pneumonectomy, single lobe lobectomy. Now this is for a lobectomy. Okay, but this is not coding for a thoracoscopic lobectomy. The thoracoscopic lobectomy code would be 32663. This is coding for an open lobectomy. Okay, so we didn't had an open lobectomy. We had a thoracoscopic procedure, or VATS, which is VATS procedure done. So option D is also wrong. The correct CPT code, as most of you have said, is going to be 32663. That is for thoracoscopic surgical with lobectomy, and 32668, that is for a thoracoscopic uh, with surgical with diagnostic wedge resection followed by anatomic lung resection. So you can see the code language. So that's what exactly happened. So a therapeutic wedge resection was performed. Because of that, because of the intrapathology intraoperative pathology report, we needed to go and do a much bigger or much extensive procedure, right? So that initial therapeutic resection could become a wedge, reclassified as a wedge resection, diagnostic wedge resection, and that's the reason why you use add-on code 32668. Okay, coders, let me know, did the explanation help, and is the guideline clear for you all? Let me know in the chat. And meanwhile, Miss Mills have shared the Chun uh, video link, so please go ahead and please review them. So this is an excellent material. Okay, so Chun is live, that's what we use at AMCI. So you will see the difference. It's a time consuming, but I would say it is worth every time you spend on it. Okay, so we also have a Facebook Chun group, you can also join over there. Okay, thank you for letting me know that the guideline is clear. And let's move on to the next one. Okay, coders. The next question, of the following, which CPT codes is most appropriately describe the encounter? Option A, 32663, 32666, uh, 32666 with a 59 modifier. Option B, 32663. Option C, 32666. Option D, 32480, 32505 with a 59 modifier. A 55-year-old patient presents with an intermittent chest pain and persistent cough that has not improved with conventional treatment. A CT scan of the chest reveals small suspicious right lung mass. A thoracoscope was inserted and pleural cavity was examined. Patient undergoes thoracoscopic lobectomy of the right upper lobe followed by a wedge resection of the right lower lobe. Of the following answers, which CPT code best describe the procedure? Alright, coders, your time begins now. Okay. So I know that there are a few, couple more seconds more left, but I can see the answers are already coming in the chat. Great job, Codis. Great job. So keep it coming. And meanwhile, I will I will just go to the next slide and I will start explaining why I have chosen this answer as a correct one. Okay, so we have in diagnosis in memory a lung mass. Procedure is a thoracoscopic wedge resection and thoracoscopic lobectomy. So two procedures was performed. Okay, and option 32663 is coding for thoracoscopic surgical with lobectomy. Yes, that was one of the procedure that was performed. And 32666 is coding for thoracoscopic surgical with therapeutic wedge resection. Again, that was the other procedure that was performed. Okay, so two procedure codes we are having, 32663 and 32666. All right, now option B is wrong, option C is wrong, because they are only coding for one procedure, and these two procedures were performed on two different lobes. And as per the guideline, if the two procedures, that is the wedge resection, is performed on one lobe and the lobectomy, which is much more extensive procedure, is performed on another lobe or on a contralateral lung, you can code them separately, right? And only thing which is you have to do is to assign 59 modifier to the wedge resection code. So option B is wrong, that is only coding for lobectomy. Option C is wrong, it's only coding for wedge resection. And option D is also incorrect, because that is coding for a removal of the lung other than pneumonectomy, single lobe, or lobectomy. Now, this is an open procedure code. We are looking at thoracoscopic procedure, not an open procedure. It was mentioned that a thoracoscope was used. And that makes option D incorrect. 32505 is also coding for a thoracotomy. So that's again an open procedure. And the correct answer is going to be option A, which is coding for 32663. That is a lobectomy code. And 32666, which is a thoracoscopic wedge resection code. And you have to assign a 59 modifier to the wedge resection code. So that makes option A correct. There you go. Great job. Great job. Yes, Miss Catherine. A for amazing job, coders. Okay, so let's move on. And yes, so now let's turn our attention to the third approach, which I didn't touch in the initial slides. So that's about the percutaneous cord needle biopsy. All right. Okay, yes. Do I sound my is my mic sounding good? Please let me know in the chat. Miss Mills, are you able to hear me? All right, so if someone can let me know whether the sound is good, that would be fine. Okay, thank you, Miss Mills, for letting me know. All right, so if you're having any sound issues, please you can just log out and come back. Okay, thank you, Miss Pina, for letting me know. So let's go ahead and let's look into decoding the biopsy procedures. All right, so first let's see the difference between a fine needle aspiration and a core needle biopsy. These are two percutaneous procedures that can be performed in the lungs. So fine needle aspiration, they uses a thin needle to aspirate the cells for cytologic examination, and these are primarily used for diagnostic purpose. Then we have core needle biopsy, which uses a much larger needle to obtain tissue cores for histopathologic evaluation. So both different procedure, we have to use two different CPT codes, and also it gives totally different information to the pathologist. Okay, so both are different procedures. Now, these both procedures are usually typically done under the ultrasound or under the image guidance. So the CPT code 32408 is the one which is used for a percutaneous core needle biopsy of the lung or mediastinum. And this code is actually includes the image guidance. Yes, whether it's a CT guidance, whether it's an ultrasound guidance, fluoroscopy, or an MRI, those image guidance are included, and these image codes are not reported separately with the CPT code 32408. All right, so that is one of the important guideline which you have to remember. Image guidance are not reported separately with 32408. Now, these codes are also reported once per each distinct lesion they sample. So if the surgeon biopsy one lesion in the right lung and other lesion in the left lung, that is two different lesions. Okay, so you report only once per lesion. And the third guideline says that if multiple biopsies are performed, so we have a set of scenarios how to code them. Okay, first one, when a core needle biopsy of the lung or mediastinum is performed using imaging guidance, and during the same session, a core needle biopsy is also done on a different site, like for example, a liver, you can report both procedures. Okay, and the image guidance used for the additional site can be also reported separately as long as it meets the guidelines. But to show that these two are distinct procedures performed on different anatomical sites, you must append a modifier, and you know what modifier to append. That would be 59 modifier. Okay, so if it is two different anatomic location, like if you had a core needle biopsy on the lungs and a fine needle biopsy on the liver, and when a fine needle biopsy or fine needle aspiration on the liver uses an ultrasound guidance, if the guidelines allow, you can assign that ultrasound guidance as well. Okay, next scenario, when both fine needle aspiration biopsy and core needle biopsy are performed on the same lung or same mediastinal lesion during the same session on the same day using the same type of image guidance, since we are using or since the image guidance is shared here, you cannot report them twice, so you have to assign 52 modifier to one of the code. And third scenario, if a fine needle aspiration biopsy and core needle biopsy of the lung or the mediastinum is performed on separate lesion at the same time and the same day using different type of image guidance, both the image guidance biopsy codes may be reported separately, and all you have to do is to assign 59 modifier with one code. And next scenario, when a fine needle biopsy is performed on one lesion and core needle biopsy of the lung or mediastinum is performed on a separate lesion. Now this is at the same session on the same day using same image guidance, both modality specific image guided FNA biopsy codes and 32408 may be reported separately, and one code should be appended 59 modifier. And the final scenario, when a FNA biopsy is performed on one lesion and a core needle biopsy of the lung or mediastinum is performed on a separate lesion at the same session on the same day using different image guidance, you will report both modality specific image guided FNA biopsy and 32408 may be reported separately, and 59 modifier is only to be assigned to one code. All right, so from this summary it might look a bit confusing, but easy. There's an easy way to remember coders. Okay, there is only one scenario that requires you to code 52 modifier. You know what? Yes, when same lesion, same image guidance is used. Yes, when both FNA and core needle biopsy are performed on the same lesion and same guidance are used, only in that scenario you have to use a 52 modifier. And in all other scenario, you can report actually two CPT code and you have to assign only 59 modifier. Okay, so you only need to remember or keep in mind of this second circumstance. Okay, are we good? All right, so quickly, let me do an exercise. Of the following, which CPT coding codes must be, or which CPT code most appropriately describe this encounter? Option A, 32408. Option B, 10005 32408. Option C, 10005 32408 52 modifier. Option D, 1 1000 or 1005 32408 with a 59 modifier. A patient with a multiple lung lesion requiring tissue diagnosis. During the same session, fine needle aspiration biopsy is performed on one lesion and a core needle biopsy is performed on a different lesion using same ultrasound guidance. Of the following answers, which CPT code most appropriately describe this encounter? Coders, you got 2.5 minutes. Quickly, you can let me know the answers in the chat. All right, coders. Oh, great answers are coming in the chat. Excellent job. So I know I have to uh, start explaining the scenario for you because yes, you're correct, Miss Mills. Chat is on fire. You all are putting great answers in the chat. So let me quickly walk you through this one because we are almost at time. And we have patient with a multiple lung lesions, and there was a FNA or fine needle aspiration done on one lung lesion and a core needle biopsy that is performed on the second lung lesion. Okay, and same image guidance were used. Okay, so these are the CPT code 32408 and 1005. So the guidelines specifically stated that when a fine needle biopsy is performed on one lesion and a core needle biopsy of the lung or mediastinum is performed on a separate lesion at the same session using and on the same day using the same type of image guidance, then what you have to do? Both modality specific image guided FNA biopsy code and 32408 may be reported, and one code should be assigned a 59 modifier, right? Okay, so this is the exact same scenario. We had same uh, image guidance, right? But two different lesion. So we can assign both. Only thing which you have to do is use a 59 modifier with one. So option 32408A is incorrect because that is only coding for one procedure. Yes, one core needle biopsy. And option B is incorrect because it is missing to code a 59 modifier. Option C is incorrect because that is coding for a wrong modifier. We need to code 52 modifier in this 59 modifier in this scenario. And option D is the correct answer. 1005 and 32408 with the 59 modifier. Okay, so this is the correct answer. All right. Okay, I can see one question from Starry Sunny. I will respond to that question in the upcoming slide. Okay, so you all did a great job, Coda. So let's quickly move on to the poll scenarios. Okay, so and review what we have learned from these guidelines. So first question: This is a rapid fire. You can place the answers in the chat. FNA biopsy and core needle biopsy are performed on the same lung lesion and using same image guidance. How will you report this one? Report both without a modifier, report one code only, report both with 59 modifier, report both and append 52 modifier to 1. What say you coders? Quickly let me know in the chat. An FNA biopsy was performed, a core needle biopsy was performed, and both was performed on the same lung lesion and same image guidance were used. Okay, okay, great, great. You all are nailing these respiratory scenarios. That is right, Catherine. Coders, you are doing amazing, amazing job. And yes, this was the only scenario when I said that you have to use a 52 modifier, right? And one of the coder did ask, why are you using, or why are we using a 52 modifier in this scenario? One, the answer is that that is the CPT guideline, how which we have to proceed. And you can see when FNA biopsy and core needle biopsy of the lung or mediastinum are performed on the same lesion at the same session on the same day using the same type of image guidance, 52 modifier should be used with either FNA biopsy code or core needle biopsy or core uh, lung or mediastinal biopsy code, because we are sharing both. In this scenario there is a sharing of two image guidance, right? It's on the same lesion and two different technique, but the image guidance is the same. Am I right? So it would be inappropriate to claim for both image guidance. That is a reason why we have to use a 52 modifier. So did the explanation help? Please let me know. Imaging is shared, so we have to, so one service is reduced here. Okay. Yes, that's the reason why we use a radio service. All right, so I hope the explanation helped. Let's move on to the next one. FNA biopsy and core needle biopsy or core biopsy are performed on the same lesion but using different image modalities or imaging modalities. What is the correct coding? Option A, report one code only, report only one. Option B, report both without modifier. Option C, both report both append 59 modifier. Option D, report both append 52 modifier. FNA biopsy, core needle biopsy. Two different biopsy performed on same lesion, but here two different image modalities were used. Okay, this is going to get easy. You all know that which scenario you have to use 59 modifier and which all scenario you have to use a 59 modifier, right? Absolutely correct. Option C is the correct answer. When an FNA biopsy and core needle biopsy of the lung or mediastinum are performed on the same lesion or at the same session at the same day using two different imaging guidance, you can report both and use a 59 modifier. All right, excellent job. One more question. A CT guided lung core biopsy 32408 and a CT guided liver core biopsy 47000 and 77012 are performed on the same session. What is the correct coding? Option A, 32408 only. Option B, 32408 47000. Option C, 32408 47000 77012 with a 59 modifier. Option D, 32408 47000 with a 52 modifier. Right, Curtis, let me know in the chat. So we have a CT guided core biopsy that is performed on one on the lung, and we had a CT guided liver core biopsy that is performed on the liver, right? So two different anatomic location. Absolutely right. Absolutely right. It is option C. So the guidelines state when core needle biopsy of the lung or mediastinum with image guidance is performed at the same session as core biopsy of other site, a site other than the lung or mediastinum. Okay, in that case, you can report both. Only thing you have to do is assign a 59 modifier. All right, coders, let me know how did you do from the way you were answering. I think you all nailed these guidelines. Okay, and if you think you need a little more practice, that's absolutely okay. Because remember, I always say mastery doesn't happen in one session, it happens with consistent learning. Repetition is always the key, and you have the right support here with us at AMCI. So don't worry if you need to watch the playback. Playback is always here in our AMCI channel. Yes, coders, if you feel like you need more practice or want to revisit today's concept, head over to AMCI YouTube channel. So it will take a while for me to put this video into the playlist, but you can also watch all the other videos. Yes, inside this channel, you will find a dedicated playlist that is known as CPT Guideline Mastery Sessions. And this playlist includes all our previous session recordings where we have broken down the topics step by step in details. So take your time, go back and rewatch and reinforce your guideline or your understanding. And I truly hope these videos will be very helpful in strengthening your coding skills as well as boosting your confidence. Okay, so with that, we come to a conclusion of this week's CPT Guideline Mastery Sessions. If you enjoyed our video, please don't forget to smash that like button, coders, and subscribe to our EMCA channel. Also, share it with someone who really need to see it. And I have placed the survey link in the chat. I kindly request you all to fill out that form. Let us know how we did. And also, if you have any questions, you can also mention that in the survey link, and we watch all or we read all your surveys and feedbacks, and I truly appreciate if you can fill that survey form so that we will know whether we are doing something good or we have to improve. Okay. Okay, thank you, Starry Sunny, thank you, Catherine, thank you, Linda, thank you, Vinadi. So Chorus, please do fill out the survey form, and thank you, Miss Mills, as well. So with that, I'm going to close out this session. We will be back next Friday with another topic and another learning session. Till that, coders, stay safe, keep coding, enjoy coding with AMCI. We'll see you next week. Till then, goodbye and enjoy your rest of the day and happy weekend.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.